Bernie Thompson, Roseville.
Patricia Wilkins, Charleston, Missouri.
Rosemary Prude, Charleston, Missouri.
Donnie Glover, Fulton, Missouri.
Henry Paul, Jefferson City.
Delma Driver, Sykes City, Missouri.
All right.
Walker West, Columbia.
Isabella Elder, Columbia, Missouri.
Mary Clark, Columbia, Missouri. Sharon Wright, Columbia, Missouri.
Marietta Monroe, Columbia, Missouri.
Kay Smith, Columbia, Missouri.
And I would be remiss with not forgetting our staff that's here, that's traveled with you all, and also that's helping the center to put on this great event. So the coordinator for Southeast Missouri, please stand. And all right, Southeast Missouri. That's what I'm talking about. That's how we roll. Miss Adrian Hunter Green, Southeast Missouri. And of course, we have to have Mr. Andrew Erb here. He is the person, the tape musician, is what I call him. Well, I'm going to go ahead and transition because I know you want to hear this wonderful presentation today. And the reason why, you know, sometimes when you transition from one decade into another, that's when health issues come about. Well, I understand this one quite clearly now. And so I said, there's something that the center, I feel, and I approached Ms. Yvonne about it. I said, I think we need to speak about the digestive health matter and how serious it is in the senior population and also particularly the minority population as well. And thanks to the wonderful partnership with the Lincoln University School of Nursing, in which has turned out to be a wonderful partnership. As a matter of fact, before I introduce our presenter, there are some articles that she contributed to for the Healthy Aging newsletter for the summer, and you will also find those to be very informative and inspirational. So at this time, I'm going to transition and introduce our presenter for today. Michelle Nolph is a registered nurse. She has a Master's of Science in Nursing and is an adult nurse practitioner. She has been a nurse for almost 20 years. Michelle's experience ranged from critical care nursing, working in the ICU and an emergency department. She has 2 areas of specialty as a nurse practitioner. They include disease of the GI tract and hospice nursing, which is the care of the dying patient. Her nursing career has been paved with many education opportunities, such as working with new graduates to prepare them for the clinical workplace, nursing boards preparation, to working with students at all levels in nursing schools. Michelle currently teaches at 3 different universities. She is an RN educator at Lincoln University, State Fair Community College, as well as teaching at the master's level at St. Louis University. Michelle's passion in nursing is to advocate for patients, families, and other nurses to make sure we all are able to care for patients to the best of our abilities. Without further ado, please welcome Ms. Michelle Nolph.
Good morning. Thank you for having me. Thank you so much. I feel home right here on the front row. I'm from Columbia originally. Yes, I'm a cutie. I've lived here with my husband and my 2 children, well, our 4 children really. 2 of them are human, 2 of them are canine. I have a driver, she's just driving, so I have an app that I might periodically say, okay, she's parked her car, so just disregard. But we've lived here over 20 years now, and I have the honor and pleasure of becoming a nurse right here at Lincoln. So I'm a grad, and I get to teach here. And I've been honored to be a part of your summer school and talk about something that is incredibly important to me which is digestive health. And as mentioned before, most of my nurse practitioner work has been in digestive health. People say to me, why do you want to work with people's colons? And I do it because of exactly what we're going to do today, which is educate the masses about an important disease. And one of those things that I deal a lot with in that world is colon cancer. So I'm going to talk to you today about that subspecialty area of digestive health. But digestion is such an important process, and we all can have great days and we can all have some pretty terrible days, and there's not too many, there's a fine line between the two. We have a real struggle, and so I hope that some of the information that is in the newsletter this month will be helpful to you, because I know that constipation, which is one of the topics that we talk about in that newsletter, is something that is pretty prominent, and for many, many different reasons. I am of the age of, I am calling myself the sandwich generation. I am taking care of my kiddos, who are everywhere, here, there, and everywhere, literally now everywhere that she can drive. And I'm taking care of my mother-in-law, who is struggling through some medical issues. And so it is really difficult, especially in the digestive situation, when we have pains that require us to take medication, that requires us to really pay attention to our bowels. And so I hope that some of the information that I've provided for you there will be helpful to you beyond what we talk about together today. I'm a very informal speaker. I might move around a little bit, but if you can't hear me at some point, flag me down and tell me to get back over to where you can hear me. And if you have a question about something, don't hesitate to just stop me right there and we can talk about that. So I'm going to go ahead and get things started this morning. Now I can advance? Okay. So my lecture will be up here. You do have the lecture notes that feel free to take notes and ask questions and things as we go along. But I'm calling this lecture A Tale of Two Stories because there is two ways that we can go. Every single one of us will be on a path or the other. I would like for the majority of us to be on what I call the molehill path, and I'll explain that here in just a few minutes. But this is a story about two different ways that we can manage disease such as colon cancer. This is some information about myself. So let's talk a little bit about what we need to do in terms of the background knowledge we need for colon cancer. So let's discuss this in two ways. We can approach this problem by climbing a very tall mountain. This particular mountain was where I was about a year ago. This is my husband down in the forefront of this picture. This is out in Colorado. Has anybody been out to see the mountains in Colorado? An unbelievably majestic place. I would love to be at that mountain giving this lecture to all of you. We could go on a trip. But this is a much harder way of managing a disease by trying to climb the steepest, tallest mountain. And that's the way that I feel like we have to manage this disease if we don't go through the simple steps of screening and the procedures that are simple to be able to diagnose this disease as a polyp or a small, manageable disease, like a molehill. I would much rather climb this. Especially today, right? In this heat, I'm going to pick this route. So let's give you an example. I have a 72-year-old male. He's a father of 4. He's a husband. He's been married almost 50 years. He's a grandfather of 8. An otherwise healthy guy up until his 72nd birthday. So he's had very little health care over that time. Of his 72 great years on this earth, and he has felt pretty darn good up to that point. He's had a few things here and there, but nothing extensive. And he's not a big fan of going to the doctor. You know anybody like that? Yeah, I do too. I know a lot of somebody's like that. So then something changed. Right around his 72nd birthday, he started noticing something wasn't quite the same. And it can be as simple as your stools change a little bit. Or in his case, he saw some blood in his stool. Now, can we see some blood in our stool periodically? Here and there. But if it keeps on and it doesn't stop and you don't have a good reason for it, it's a no hold. Let's go see somebody, okay? So he was reluctant. He didn't really want to go. He didn't really want to take the advice of his family, who was saying, come on, let's just go check it out. It might be nothing. So he ultimately decided, okay, I'm going to go on in. Well, interesting history for him, which is a little bit different than sometimes the way we find it. He had a son who in his 40s had precancerous polyps removed. So his son, about 8-10 years ago, found out that he had some precancerous polyps and he had those removed. Dad, however, decided at that time, oh, no, I'm not going to go in and have any testing done. It'll be okay. So he has a bit of a family history, which we'll talk about some of those caveats here in just a little bit. So after much showing along and helping him down the path of maybe we should go in and talk to somebody about this, he reluctantly had a colonoscopy. During the time of that testing, he had a polyp, 2 polyps actually, removed, and they found a tumor in his rectum. So this is certainly what I would consider that mountain kind of an approach. Would you agree? So when I talk about the colon, I'm going to be talking about this large tube. That's really what I'm talking about. That's your large intestine. The colon is a portion of, kind of the last road before food and drinks get expelled. So when I talk about the rectum, I'm talking about the very end of the colon. And then there's different segments of the colon that we can have involved with colon cancer. But I'll tell you, research shows that the majority of colon cancer happens on that side of our colon. It happens on the end of our colon. So it happens on what we would consider the left side of our colon and the rectal area. So some of my numbers that I'm going to give you here in just a few minutes don't always match up exactly with other statistics, because some people say colon cancer is separate from rectal cancer and other people say they go together. So it just kind of varies a little bit in numbers. I want the number to be 0 no matter what we're talking about. I want there to be no colon cancer reported. But when I talk about the colon, this is the tube that I'm talking about, and for the majority of cases, that left side is where we tend to see the tumors or cancers that we find. Now, what do we do? What do we do for this gentleman when we find this mountain of a problem, right? So what he is going to have to do is go through radiation and chemotherapy, which I'm not going to go into too much in depth, but I think we all have at least enough background and unfortunately enough experience with ourselves and others perhaps that have had to go through those types of cancer treatments. And in order to be able to just approach a tumor in the colon, sometimes we have to start with chemo and radiation before we can even go in to have surgery, which is exactly what we're going to do for this 72-year-old gentleman. He will have, hopefully, a cure from this cancer if we can get the colon tumor or the rectal tumor shrunken with the radiation and chemotherapy, and then we'll do surgery for that. So we do have the ability to treat colon cancer, but it's really challenging. It's a lot of steps to go through. There's a lot of processes that our body has to go through in order for us to be able to get to the point of doing surgery in some cases. But removal of a portion of, or a large portion in some instances, which I have an example here in a few minutes that I'll go over, where we can remove a significant portion of the bowel, and within about 5 years, if no cancer returns, we can consider that to be a cure from that course of cancer. I don't really think anybody wants to go through this, though. Would you agree? No, I don't. I don't want my family to go through this. Unfortunately, this is about as close to my family as it can be. My husband's best friend's father is who I'm talking to you about today. So he gave me the okay to kind of have this conversation because he said, I really don't want anybody else's story to be like mine. And we don't know the end of his story yet. This is happening as we speak. So my hope is that he will have a cure. But we will be able to do this differently if we come at it from a little bit different angle. So I like to look at things in multiple ways, and this next story is maybe a better angle or a better way to go about becoming involved with a disease like this. So let's talk about the other way of going. Let's talk about the molehill here. So we have a 50-year-old male who goes into his primary care's office and sees his nurse practitioner. And he does this on an annual basis. He sees his provider every year to check up on things, to check blood pressure, to check and make sure that all of his immunizations are where they need to be, et cetera, et cetera. In doing so, screening recommendations are recommended for him for his colonoscopy. So at the age of 50, the average bear should go in and have a colonoscopy. Now, I'm going to talk to you about some specialty things here in just a few minutes that would change that, but at age 50, just about everybody should have a colonoscopy. I rarely give a birthday card to a 50-year-old that doesn't have some kind of a poop joke on it that says it's time for your colonoscopy, right? Because that's the way it should be. Everyone should have their colonoscopy by 50. So he gets his testing scheduled. 2 weeks later, he comes in for testing. Now, he also has some polyps. So it is a disease that may be developing and we don't notice anything at all. He was not having any problems. It was just time for his regular checkup, and the correct screening recommendations were made by his primary care office, and he came in and had this testing done. And I promise you, from the other side of this coin, working in a GI office, if you go in this way, it's much easier to fit this into your schedule than it is, oh my gosh, now I'm having problems, when can we do it tomorrow? Right? Like, that's not the way you want to do this test. So he goes in, he has 2 polyps removed from his bowel. 3 days later, the office calls and says, yes, you've had those polyps removed. 1 or 2 of them were precancerous. This is what we would call that. And if left untreated, meaning if we didn't take those polyps off, if we just went in there with our camera and looked around and said, yep, there's a couple polyps, see ya, and out we went, cancer would develop. But removing them as a polyp, which on one of your handouts, you can see on this handout here, the difference between a polyp and cancer. Polyps can be removed as simply as sending a little device down the end of the scope. We clip it and pull it right out through the scope and put it in a container and send it off to the pathologist to take a look at and tell us later, yes, that was precancerous, I'm really glad we got rid of that. Because that can be the treatment. So he doesn't need any further treatment now. He doesn't need any radiation, chemotherapy, he doesn't need any of those things. And his provider says, I'll see you back in 3 to 5 years. We'll do another colonoscopy. If you have other polyps, we'll remove them then. Does that make much, much easier way of going about things, right? So the difference between the two is testing, right? Early testing and follow-up testing. So, let's do another example, another mountain example. And this might be a mountain we're familiar with. This person might be someone we're familiar with. So we have a 66-year-old male. So again, I'm kind of missing the date mark, wouldn't you agree? And I'm going to talk to you a little bit about that here in just a few minutes. But one of the things that I want you to pick up on is the fact that we picked 50 for a reason in terms of why we screen for polyps at age 50. It takes about 10 years for normal tissue to grow into one of these early forms of cancer, okay? So if I go in at age 50 and have my colonoscopy done and I have no polyps and everything is completely normal, they'll say, see you later, alligator, I'll see you in 10 years. Because we know it takes about 10 years for a cancer to develop in the colon. Not all cancers, but this particular kind of cancer. So I'm a bit late again here, wouldn't you agree?
Yeah.
So, 66-year-old gentleman who was diagnosed at age 60 with stage 4 colon cancer. So we went from, at age 50, a polyp that grew for 10 years, that at age 60, it's now moved out of the colon, and I now have cancer in the colon and the liver. So terrible, terrible way to have to go about finding a cancer. But stage 4 cancer is a pretty severe situation that we have to deal with. So Mr. King had to go through multiple therapies in order to treat his cancer. He had chemo first to shrink down the tumor in his colon and the liver, unfortunately. He had to have radiation therapy to shrink down the tumor size before we could go in and have it removed. And then 1/3 of his colon had to be removed in order to get good treatment. Now I can tell you that even if I take this much of your colon out, it changes everything. It changes everything. If you were one of those lucky few, well, lucky maybe many, that can just wake up in the morning, go to the bathroom, and have a bowel movement every day and go about your business, it all changes when we take out even a little portion of colon. When I take out 1/3 of your colon, it significantly changes your life. In some instances, it can be that we can put those pieces that are still healthy back together and still have a normal bowel movement through the rectum. Some folks don't have that ability to do that because of portions of the bowel that are affected. We no longer have the same function, so we sometimes have to wear an ostomy bag. And that is a life-changing event, even if it's for just a short time. So, 1/3 of his colon had to be surgically removed, and 70% of his liver had to be removed in order to treat this advanced stage cancer. Wow. I mean, that might have been even taller mountain than the one we saw in our picture before. Would you agree? I'm thinking this is Everest. I don't want to do a lecture there. It's much warmer in Colorado, right? Now, 6 years later, he is cancer-free. He was able, at that 6-year mark, to be healthy enough to go through some pretty extensive fight in terms of a presidential candidacy. And he has survived without needing a lot of other treatment. However, to say a part of your colon's gone and most of your liver's gone is still a pretty big hurdle to climb every single day. But he has gone on to do a great many things, and hopefully is on a path of health at this point. Survival is possible, but it's really challenging. So I much rather go the route of taking care of a disease like this when it is an easier to manage situation. Are these stories familiar to you? Too familiar, aren't they? I know. Unfortunately, we are probably all in some way touched by this disease. And sometimes we have, this disease is a little too handsy, right? It's touching us way too much. There's too much of this disease out there. So what can we do? How can we rewrite the story? We can educate. We can do what we're doing right now and get together and talk about this, because I take care of diseases that people don't really want to talk about. Would you agree? Like, nobody really wants to talk about their bowel movement. Nobody really wants to talk about those types of things. And my take on it, my daughter said the funniest thing the other day. She goes, you know, other people don't talk about the things we talk about at dinner. I'm like, no, honey, I bet they don't. We talk about, you know, bowel movements, and we talk about, you know, treatments and things like that that other people don't really want to talk about. And I get it, I understand it, but the more we work together as a team, the more we get the message out to the masses, the less numbers we're going to see that I'm going to show you here in just a few minutes on those statistics. We want to change the face of colon cancer and wipe it out. We have better things to do than take care of colon cancer, right? So let's rewrite the stories, and let's do that by knowing our risk and knowing what we need to do about it so that we can approach this in a much earlier fashion. So let's talk a little bit, I'm going to rewind just a smidge and talk about what cancer is in general. Because I know we all talk about cancer, but I don't know that we ever really discuss what it means to have a cancer or what cancer truly is. And it's truly just a group of diseases that are caused by rapidly growing cells. They damage the organs that they are in. So in this case, rapidly growing colon cells turn into a cancer in those colon cells, and they then destroy that wall of the colon. And that is truly what cancer is. It is as simple as that. If only stopping it were as simple, right? So we can have multiple reasons why we can have cancer. We can have internal and external reasons why we have cancer. Internal factors are those things like you can pick your friends, but you can't pick your family tree, right? We can't always control everything. And some of those internal factors, like having colon cancer in my family, cannot necessarily be changed. Or having another kind of a disease, and I'll talk about that a little bit more in a few minutes, but there are diseases of the bowel that put me at higher risk for colon cancer. So those are internal factors that can make this a real problem. External causes tend to be those things that we can control a little bit. And on that same sheet, I've got on the back page of the sheet that you've got in your handout, there's some interesting do's and kind of limits or don't do's. And the don't do things are the ones that fall into that external category. We don't want to overdo it. Just this Monday, an article or a research article was published talking about the connection between what we would consider bad fats, like our French fry fat, as opposed to an avocado fat, which I would love to stand here and talk to you about those things all day long. But the link between fatty foods and colon cancer has been drawn very, very closely together. And so you see on your handout, some of the things that we want to limit are those kinds of things. We want to limit fatty foods. We want to limit foods that are not giving us good nutrition. We want to limit our risk by keeping our body weight within normal limits. We want to be active. We don't want to have a sedentary lifestyle. And we want to avoid excessive amounts of things like alcohol, and we certainly want to avoid all things of tobacco products because they are really very closely tied to GI cancers of all types. So those are those external factors, and more specifically to colon cancer, but all of those things really impact all cancers, right? Cancer is really a matter of setting up those rapidly growing cells for disaster when we add some of the things that we really shouldn't be doing to our body to the mix. And we can impact cancers or try and stop cancers through all of these mechanisms that you see here. We can use surgical interventions, radiation, chemotherapy, hormone therapy, immune therapies, targeted therapies that are specific to that rapidly growing cell, and certain types of drugs. And all of these things are intended to try and interrupt that fast-growing cell. That's really what our goal is with any kind of cancer treatment. So that's kind of cancer in general. And again, cancer in general is this slide, and I'm going to be more specific with colon cancer here in just a minute. But 2 million people every year will be diagnosed with some form of cancer. 2 million. By the year 2020. Every year, 500,000 people die of all types of cancer, not just colon cancer, but all type cancer. And more than half of cancers can be prevented if we do some of the things that we're going to talk about today. So, cancer is a huge population issue, and more specific to our topic today is colon cancer. And it is unfortunately the 4th most common cancer that we diagnose in the US population, okay? So these are US numbers. 135,000 new cases will be diagnosed just this year. Just this year. And 50,000 deaths are estimated from this type of cancer alone in 2017. So we want to see a 0 here, like I would like to lose those numbers in front of that last 0, right? We would like to see a 0 here. It affects us all. I put this picture here because I do give you male examples of this disease, but it is not just men that are affected. It is not just one population or another. It is everyone that can be affected. This cancer, however, as I did allude to before, tends to pick on the 50 to 60-year-old population. So less than 21% of cancers are in this under 55 age category. Less than 21%. The majority of sufferers of colon cancer are between the ages of 55 and 85, with the average age being 67. So the average age of a colon cancer diagnosis is 67, which is 17 years past when we could be checking for this, right? And so this is a disease that really picks on this middle-aged population. So race and ethnicity, however, do impact this disease, and it is a very lopsided disease, especially in the US population. African Americans are more likely to get this disease, but it happens earlier in life. So it doesn't tend to be quite this 67 age group, it tends to be a little bit earlier. So we need to kind of shift our thinking a little bit with different populations, okay? Now, let's look at this from a race perspective. So the highest rates do fall within the African American population. So we really need to be paying attention to these high-risk populations. It does, and you'll see this in almost every single category, happen more with men than it does women. So it does tend to be a little bit more male-oriented disease, but the highest rates are among the African American population. The second highest rates are among whites, men again more common than women. And third is the Hispanic population, and again, these are U.S.-based numbers. Okay, I don't do a lot of world-based numbers because it doesn't completely tell our story, and I think that it's important for us to pay attention to what we can do right here at home. American Indian and Alaskan Natives fall in 4th place, and then last are the Asian population and Pacific Islanders. So all have a risk. But certainly our African American population is the highest risk. Now, it changes when I look at this disease cross-sectioned by race. It is the 3rd leading cause of cancer in the African American population. 3rd leading cause of death by cancer as well. So we need to do something about this, don't we? And again, men are more likely to die from this disease, and there's a lot of different caveats to that. Like I said before, men are more common to get colon cancer, but also men tend to be more like my friend that I talked to you about first, who said, I don't want to go. I don't want to go in, I don't want to know. Because if I don't know, it isn't there, right? But is that true? No. If only that were true, we could write a completely different story, and we could be talking about something way more fun, right? Okay, so most important, what do we need to think about? We need to think about how can we prevent this for ourselves and our families, right? How can we recognize signs and symptoms of this disease? What do we do about it to screen or test for this disease if we do find some signs and symptoms? And then how can we go about sharing that information? So let's talk a little bit about that. So one of the most important things that I like to bring up when I talk about colon cancer specifically, is risk. And your family history, this is my family tree right here. My mom and dad, I have a sibling, he didn't get in that picture, he wasn't with us at the time, so I tell him I'm most important anyway, so it's okay, you don't need to be in the picture. But we're first degree relatives, right? I want to talk a little bit about what that means when we in the healthcare world say, well, do you have any first degree relatives that have this disease? Well, what the heck does that mean? Well, that means mom, dad, brother, sister. That's your first branch off your family tree, and that is what we really want to know about first and foremost. Everyone else is important because at some point that one of our first degrees are going to have a first degree of their own that might have the history of this disease. I have that in this instance. My dad has had a portion of his colon removed because of other bowel diseases, and his dad died with colon cancer. Not from it, unfortunately, he had other diseases of his lungs that kept him from being able to treat his colon cancer. So it is a difficult thing because our relatives have this disease, and sometimes we have so many other issues going on we can't even treat it. But knowing your first degree relatives and the risk that you have based upon their family history is important. So do mom, dad, brothers, sisters have a history of this disease? And do their mom, dad, brothers, sisters have a history of this disease, and so on and so on and so on. So those are some of the first questions that you want to be kind of thinking about for your own history, as well as those that you love and care about, and helping them to figure out what their risks are. Then we want to talk to people about what do I watch for if in between, I like to say it this way because I'm hoping that when you leave here today, the understanding and the expectation is that the importance of getting that screening testing done, and I'll talk to you about some of those options because they're not just colonoscopies. I am not just here to say go get your colonoscopy, right? There are other ways to do this, but what do I need to be watching for in between those tests to make sure that I'm not seeing some of these red flag signs? And the signs and symptoms of colon cancer are as follows. Bowel changes. So that may be, I can go every day, first thing in the morning, no problem, and then all of a sudden, I'm completely stopped up, and I can't go at all. Or, all of a sudden, I have lots and lots of diarrhea. So that's a bowel change. Welcome, come on in. You're fine. There's a couple of spots here. There's about 3 right here. Welcome. So bowel changes are one of those things that we want to really pay attention to. Now, a bowel change can be a simple couple of days, I've been traveling and now I have some constipation and then it goes away. I don't get excited about that. But if nothing else has changed and everything in your life is about the same, and then all of a sudden we have a major change in your bowels and there's no explanation for it, we might want to get that checked out. That's a sign and symptom that something is going on inside the bowel. The feeling that you need to have a bowel movement, but once you pass stool, it doesn't give you relief. That's a sign that things are not going on quite like they should be in the bowel. Rectal bleeding or bright red blood, like my first example, that was his symptomology that he had that said, something's not quite right here. Excuse me, let's figure out what's going on. So rectal bleeding without an explanation. So there are times that we can have some rectal bleeding because I have a hemorrhoid or something of that nature. But if you don't know for sure why that's happening, I definitely recommend we get it checked out. Abdominal pain or cramping in the abdomen is something that, if persistent, can be a sign that something is going wrong in the colon as well. And then weakness and fatigue, the dreaded, this is the provider in me that says, oh no, weakness is what the diagnosis is on my chart for the day to see someone. And there's lots of reasons we can have these symptoms, right? But losing blood a little bit at a time adds up, and colon cancer causes that to occur. So weakness and fatigue may be the first sign that you have that something's not quite right. And this is my most terrifying thing to ask this last question of people and say, how has your weight been? And they go, oh, it's fine. I lost 15 pounds last month and I didn't even try. It was great. It's never great, right? Air back on, thank you. Air back on is good for everybody. It turns itself off. It does. It does. It just goes, I'm done. And then it's instantly warm in here. But unintentional, unplanned weight loss is not a good thing until we can prove why it's happened. That's something that is troublesome or worrisome, and I worry about that from a colon cancer perspective. So don't wait for these symptoms to occur. Let's get tested, and let's talk about how we can get tested and the types of testing that we can do. So I'm showing you some tests here that will go and look for those polyps. So remember on the front of our handy dandy handout here, polyps are what I'm looking for. That far left in pink up here is what I'm looking for on all of these tests that I have on the board. So a flexible sigmoidoscopy, these are $10 words is what I call them. Like this is an expensive word that simply means a lighted scope tube that we look inside a portion of the colon. And this first one looks at just that left side of the colon. Remember I said before, that's the most common place we're gonna find cancers, is on that left side. So this first test looks basically at that left side. The next test is also looking for polyps, but it looks at the entire colon. It looks at the whole colon with a colonoscopy. And that kind of a test is something that I recommend for everybody at age 50, and sometimes, especially in our higher risk categories like we talked about before, 40 to 45 might be a better age group for particularly African American populations to begin their screening, because it tends to happen a little younger in that population. The second two tests are not scope tests at all anymore. They can still look for polyps. One of them is an enema test, which everybody can't wait to sign up for an enema test, right? But what it actually does is it uses barium, which helps us to take a simple x-ray, and it coats the colon itself, and it allows for me to look for those polyps. Now, the trouble with the last two tests are I can see them, but I can't do anything about them. Right? The first two tests, when I go in and do a colonoscopy or a sigmoidoscopy on a patient, I can actually take a little tool at the end of that scope, remove that polyp and take it out. So I can not only diagnose, but I can also treat polyps with the first two tests. The second two, I can see them, but I can't really do anything about them at that stage. The last test is a CAT scan, and it's what we would consider our virtual colonoscopy. Has anybody heard about those? We just started that technology in the central Missouri area. It's taken us a little while to get the more specific CAT scan machines that it takes to do this test. But we have great tools to be able to look for those polyps as polyps. This is an example of a colonoscopy, so one of the scope tests that I mentioned before. And like I said before, I look throughout the entire colon, which is that larger in diameter end of our digestive tract, and we use a small lighted scope to look through the entire colon itself and see if there are polyps that can be removed. And then we can remove them while we're doing the test. And then we end up treating any kind of polyps that we might see. Other types of tests that help us to identify whether or not colon cancer might be present are tests that can be done on the stool itself. So we can have a bowel movement, collect a small sample of that stool, and look at it in different ways. One of them is a little card that you may have been sent home with from your doctor's office, where you collect a little bit of stool, you put it on the card, you put it in the envelope, and you send it off, and they look for blood in the stool. That's what it's looking for. Because there are many times that we have blood in our stool, and we can't see it. You don't see it in the stool, I don't see it when I do an exam. It's too small to be picked up by the naked eye. So we can look at that with a chemical test, like that stool card that you may have encountered at some point. Now, we have two fancier versions of that, that's how I describe them anyway, that look at stool a little bit more specifically than just blood. Because like I mentioned before, we can have blood in our stool and it's not cancer at all. It can be for other reasons. But we have two newer tests that look for either cells themselves or the DNA of a cancer cell in that stool. And these are remarkable tests. I love to have this as an opportunity because these can be done every year. I don't have to go through the process of taking a bowel prep and doing a colonoscopy every single year. What I can do on an annual basis is have these stool tests done every year when you do your general physical at the physician's office, and have this type of screening done. So it can be much simpler than just that colonoscopy. Sometimes this is all I can convince someone to do for me. And that's okay. I know the risk a bit better. If this test comes back and it says it's negative, I have about a 90% chance with the second two tests. I have about a 90% chance of saying, you probably don't have cancer. I have a much better way of saying, okay, and I feel a little bit better about not really pushing down the path of getting some of those more invasive tests done. Does that make sense? So these are doable, right? These are doable. But here's that one test that everybody hates, right? I mean, it's got a slide of its own because everybody freaks out about this test, right? Yeah, rectal exam. Well, let me tell you that doing a rectal exam is an important part of a colonoscopy or a colon evaluation, but it is not the end-all be-all. So if you are just adamantly not comfortable with that, there are other ways of going about doing this. Now, when we do a colonoscopy, we do have to do a rectal exam, but I always tell my patients, you get to go to sleep first, and then I can make sure that my scope will go where it needs to go, right? Yeah. But a rectal exam has changed a little bit over the years, and they've done a lot of study to realize maybe checking to see if there's blood in the stool from doing a rectal exam isn't the best idea. So a lot of providers are kind of going the path of saying, okay, I can skip this if we do one of the other things, okay? And so a rectal exam, albeit though an important caveat for some other diseases, some of us in the room, not us, some of you in the room have to have this test done to check your prostate. Some of us don't have one of those. But from a colon cancer perspective, a rectal exam has kind of changed a little bit, and maybe some of those other stool tests would be a better choice. Okay? So, I like rules. I'm a rule follower. I like to know what the plan is. I like to know where I need to go and what to do. So I'm going to give you the American Cancer Society's set of rules. Yes?
I know you said we could ask a question.
You bet.
Say you had a colonoscopy.
Okay.
And they say we found some polyps, come back in 3 years.
Okay.
Well, say in the second year of that third year that you're supposed to go back, you start having some of those symptoms that you talked about, like bowel changes or weight loss.
Yes.
Should you go back, well, that was my first question, but then you mentioned these screening tests. So should you go back and say to your doctor, okay, I know I'm not supposed to come back for another year.
Right.
But I've had these bowel changes, this weight loss. should I even suggest about these screening tests before I
Right.
take another colonoscopy?
Good question. Did everybody hear her
Yeah.
question? I will repeat, yes, I will repeat it. So the question is, I had my colonoscopy, I had some polyps found on the colonoscopy. They said, I'll see you in about 3 years. The 2-year mark comes, and now I start to have some signs and symptoms. What do I do? So you're absolutely correct. Her recommendation was, should I go in to the provider and say, I'm having these symptoms, even though you told me I didn't have to come back for 3 years, I'm at the 2-year mark and now I'm having some symptoms. You're absolutely correct. Go in, no matter what, even if it's 6 months down the road. The problem that can occur is that we see a lot of polyps, but we can't see every single polyp that is on a colonoscopy. We know that about 80 to 85% of the polyps that are large enough to be seen, we can pick up and see in a colonoscopy if your provider is coming out of the colon slow enough. So it's possible that something else is going on. So you're absolutely correct in going back in and saying, this symptom is new, how are we gonna go about assessing this? It's possible that a polyp remained in the colon and we didn't see it during the first test. That's completely possible. We don't like for that to happen, but it is possible for that to happen. And it's possible that it's something else, totally different that we really need to address in a different way than we would a colon cancer. So you're absolutely correct. Go in, talk about the symptoms that you're having. Don't be afraid to, go sooner than their returned recommendation and figure out what's causing those new symptoms. Does that answer your question? Perfect. Any other questions? Yes.
I noticed that the recommendation on the, I've read everything
Yes.
in here, and it's giving 10 years.
If there's no polyps at all found.
However, different providers
Good
give
question.
ranges from 3 to 5 years to 6 years.
Right.
And I don't understand how they choose.
Good question. So the question is, when there's no changes to the colon at all, 10 years is the recommended follow-up for a colonoscopy. However, certain providers may say to you, well, I want to see you back in 5, or I want to see you back in 3, or I want to see you back in whatever, the number they throw in the air. They don't do that. But that can happen. So here's the things that we as providers have to consider or factor in to help us to decide, are you at higher risk based upon some category? So is it that you have a first-degree relative with colon cancer? I would probably make you come see me more often than 10 years, even if your first colonoscopy was normal. If you had any findings in that colonoscopy. So we can have different kinds of polyps. A polyp is not a polyp is not a polyp. They can be a little bit different. The ones that I have talked about more specifically this morning and the ones that I'm more nervous about are the ones that have that precancerous tendency, the ones that under the microscope have some cancerous changes, but they are not progressed, like this sheet shows, into a full-blown cancer, okay? So that type of a polyp is definitely more worrisome. Now, what complicates this even further is the better our pathology gets, or the better the looking at those cells get, the more muddy the water gets, because we go, okay, well, we now have new categories of things that might cause us problems, but we don't really have enough information to tell us the long-term risk of that. So there may be some of those caveats that help your provider to decide when they want you to come back. I'm a realist, and I'm going to tell you, no matter what your provider says, your insurance may think differently. Am I right in saying that? Well, we could talk about that for days on end, but I won't. But that is a very valid question. So here's my recommendation as a provider of care. I say to all of us, myself included, because I've had these things happen to myself, my family members, those types of things. Don't be afraid to say, help me to understand why you want me to come back sooner. I need the data. I need to know why. Because if you don't know that, you might be stuck paying a bill for something you didn't need. And that's not okay for anybody. I mean, that doesn't help the system in any way. So excellent question. Now, from a individual perspective, I can't really tell you. I don't know exactly what the thought process might be in terms of coming back sooner. I know that individual providers can sometimes be a little gun shy about something they might see on a test that they go, because of this, it's not really developed into anything yet, but I really want to keep an eye on XYZ. That's many times the reason why they decide to do something like that. Excellent question. Yes?
Even though you may not have had anything found in your exam, and you may not have a first relative, don't they take into account your overall health
Yes.
and the fact, your lifestyle?
Absolutely.
Because as we know, the older we get, our body slows down. It does not process food in the same way.
Correct.
But we tend to think that we can still do the things and eat the things that we have in the past.
You are on to something, my friend. We want to eat like we are 14. Right? I have a 14-year-old at home and I'm like, are you kidding me? How can you do that? And then 2 hours later, you're going to do it again, right? But you're absolutely right. So our bodies change over time, and the way that our body adapts to what we keep doing to it is definitely going to change over time. And so we don't digest the same way as we once did, et cetera, et cetera. And as you mentioned before, like this little do's and don'ts sheet says, if we do a lot of the don'ts, we probably need to be screened a little bit more closely and a little bit more frequently. Excellent point. Excellent point. Yes, you had a question.
So I don't know if it's because we were preparing for this for the last 6 months. I don't know if it is that my colonoscopy should have happened a year ago and I've not attended to it. It's my return. I don't know
It
what
happens.
it is. But I have been noticing more and more the commercials for do-it-yourself kits on the
Yes.
TV.
Yes.
And so I don't know if it's my
Heightened
if
awareness?
it's my heightened awareness because my neglectful behavior, my heightened awareness because of my preparation for this. I don't know what it is, but I see it more and more.
Yeah.
What do you think about those? And should we invest in take home and do it yourself?
Okay, excellent question. Did everybody hear the question? Okay, so cheers to you for just awareness. So whether or not it's because I should have done it a year ago or I need to do it next month or whatever that is, being aware is the first step. So that's great. Don't worry if it's been a year longer, that's okay. Going is the most important thing. The second thing I have to say about that is there's something called the Hawthorne effect. Does anybody know what that is? It's, I don't notice any of these things. My daughter just started driving. And so she said to me, oh my gosh, everybody has my car. I'm like, no honey, those cars have always been out there. You just didn't know to look for them, right? Like she's like, everyone has the little Honda that I drive. I'm like, no, they really don't. They were all there before, but that's called the Hawthorne effect. So what your mind is saying to you, I need to pay attention to this thing, and now suddenly that thing is everywhere you look, right? And that's common, that happens. And you're in two ways that's happening for you individually, but two, those tests are becoming more and more marketed, so there are more of those ads and things for a test like that. It depends on the test. So I wouldn't just say across the board, yeah, go grab one and let's see what happens. I highly recommend partnering with your provider that you have seen over the years because they know you as well as anyone from a medical perspective and get their advice in terms of availability. So here's the thing, where you live matters. What I have available in Jefferson City is not what I would have available if I worked in New York City, right? And so it may be that that is the best first step for someone is to do one of those home tests like I talked about. And that FIT test and all three of those stool tests were ones that you would be sent home with. But what I do recommend is this. I recommend your provider be the one to give you whichever test that is, because they need to be educated on how to read the results. That's the biggest key with any take home anything, is who's going to interpret this data for me. Because I can get all kinds of information, and if I don't know how to read it as a provider, I've spent money I didn't need to spend. Because I don't know what to do with it. Like, I may get a lot of things and I don't know what to do with it. So make sure that you're touching base with your provider, meaning your primary care, your local doctor that you, or nurse practitioner that you see on an annual or a regular basis, and touch base with them and say what's available. Because it may be that that's where we start, is one of those stool tests at home where you send it off, and then we decide from there where we need to go. Does that answer your question?
Yes, it does.
Awareness is the key, so you're way ahead of the game. Yes?
If you've been consistent having your test
Yeah.
from age 50, what is the age you discontinue having?
Excellent question.
Now
So,
that you have to repeat.
yes, so her question was, if you've been doing your testing from age 50, when do you stop? Do you just do it and do it and do it? Not necessarily. So the question that I always ask is, what is the life expectancy of this individual? If I expect them to have a relatively healthy next 5 to 10 years, I don't care how old they are. I have recommended colonoscopies for 90-year-olds because they are a healthy 90-year-old active functioning individual. And I anticipate them to have a healthy 5 to 10 years. I have not recommended colonoscopies for 47-year-olds who have a very poor life expectancy to make it to 57. So the date doesn't really impact as much as the life expectancy does. So that's an excellent question, and that's a tough decision, but it is your decision. It is not something that an outside source will tell you what to do. It is, these are the options that we have, and let me help you to decide. That's how I approach taking care of my patients, is we are a team. These are the things that we have available for you to do for testing or whatever that may be. Because face it, there's a lot of tests out there, not just for colon health, but there's a lot of tests out there like, do I need a mammogram? Should I do a rectal exam for my prostate? Do I need, what do I need to do, and at what point do I decide I'm not going to do that at this point forward? And I always tell people, just because today you decide you're not going to do this does not mean 3 weeks from now you change your mind. And if you change your mind and it's still a safe, available option, then we cross that bridge when we come to it. I'm very, very big as a provider when I see patients that come to me for their colon health or for any kind of healthcare advice. I'm a huge proponent for being a teammate, not just your coach. You know, we do this together, and we'll decide what's the safest thing together. Does that answer your question? You're welcome. Medicare has their own recommendations about things, and 80 is about the cutoff that they talk about some of those tests. But everyone is different. Everyone is different, and the need is different for every individual. Great. Any questions? Any other questions at this point, or we'll jump right back into our screening? Excellent, excellent questions. Okay, so I like the rules. I like to know, when should I get this going? What should I do? How often should I do it? So first and foremost, know your risk. Get tested on time or early, depending upon the patient population that we're talking about. Age 50 is the cutoff for general population. And that's what I talk about most in terms of colon testing and stool testing screening. So at age 50, we should start the conversation about, let's do our colonoscopy, or let's do that sigmoidoscopy, or let's start with one of those stool tests, right? So that's age 50. Then we always want to make sure we're doing our follow-up. As you mentioned before, you said, I've got a 3-year follow-up for that example. Waiting 5 years or 8 years is probably not the best choice, right? We have those intervals for a reason, and the reason is this, again, and I know I keep going back to this, but we know how fast things grow. And if you have a personal history of having a polyp removed that was precancerous, I'm probably going to see you back in 3 years. Maybe sooner than that if it was a little more advanced than just a polyp. Does that make sense? So make sure we always do our follow-up that is recommended at the interval that it's recommended. So make sure that we're going back and having that testing done. And last but not least, and really I would love to talk for weeks on end about this last bullet point, but it is about giving your body the things that it needs and not giving it the things that it doesn't need. So that's our do's and don'ts list on the back here. Eating a healthy, fiber-filled diet full of colorful fruits and vegetables is a very great idea. And it's a great idea for a lot of different reasons, but one of those reasons is if we don't eat those types of high-fiber, colorful fruits and vegetables, our colon doesn't have anything to do. It doesn't work very hard, right? And when we don't work out, so to speak, we need to do that for our colon too. When we don't give it that high-fiber diet that's full of nutrients and moisture that we get from those kinds of foods, the colon has very little to squeeze against. And that's what the muscles of the colon really want to do, is they want to squeeze against something, high fiber, to be able to have a healthy bowel movement. So that's one of the biggest things in terms of following a healthy lifestyle that I say to people, and they go, you already told me that. I know, because it's important, right? It's a really important part of our healthy digestive tract is eating the foods that the body really has to work hard to process, and it has the ability to utilize those fibers and fluids and things in that food to nourish our bodies. Exercise, stay active, keep moving. Object in motion stays in motion, right?
When we talk about the colon, I believe we have to bag all the way back and talk about what you're talking about now. Because normally when we go for food, we have 3 things in mind: what it look like, what it smell like, what it tastes like.
Exactly!
Nobody look for anything that's nutritional.
Right! Some of our food doesn't even look like food.
First thing we say when we eat food, oh, this tastes good.
Right.
But is it good?
Is it good? Right. So just because it tastes good does not mean it's good for me. So I have one rule. If what you want in ease takes away something in health. And what do I mean by that? So I'm talking about the cinnamon roll that comes in a plastic bag, right? Is that food? I need to talk to my 14-year-old. He wants it to be food, right? But it's an over-processed piece of, I don't really know exactly what, because I can't pronounce all the words that might be on the package that it came from, right? So those are my rules. If it's really easy for you, it probably isn't as healthy as it needs to be. But if it takes me a little bit of time to plant a plant and grow my tomato and pick it from the plant and clean it off and eat it, it took me a while to get it where it needed to go, that the nutrition is going to be in it, right? So you're absolutely right. Does it look good? Does it taste good? What was the last one? Smell good, exactly. Does it smell good? Now, we don't really necessarily want to talk about my colonoscopy that way, right? But you're right. So we need to make sure that we're considering all of those factors in terms of what we're putting into our body so that we're not making it work extra hard and cause these kinds of problems to occur. Very good. Okay, and then things that we talked about earlier a little bit that we want to use in moderation are alcohol, those types of things, and then avoid tobacco products. All of those types of things put us at much higher risk from a colon cancer perspective. And all of those things are shown right here. on your handout, and I love this handout. The American Cancer Society put this handout together. This is on the back side of my little polyp picture that I've got for you. And this is just quick and dirty. I like easy. I love it. Do these good things. Eat those colorful fruits and vegetables. Make sure you have a diet full of fiber. I am the fiber girl. My friends really don't like me when it's time to have a cookout because they're like, we don't want to eat that salad. Well, you're gonna, because you need it. Because I know you haven't had enough fiber in your day already. I'm the fiber girl. Make sure we're keeping our body weight healthy. Make sure we keep moving. And it doesn't matter how we move or why we're moving, just move. Right? I don't have to have anything special. I don't have to have anything fancy. I just want to move. I just want movement. And healthy choices in terms of lifestyle choices. So, who's high risk? As I mentioned before, we have to be thinking about high risk categories. And the risk goes up the more people we have in our family that have this disease, our risk goes up. When we have a personal history of this disease, our risk goes up, and we talked about that a little bit with some of the discussions that we've already had, in that if I have a history of colon cancer, I need to be even more vigilant than the average person in getting my testing done. And if I have a history of those polyps of any kind, I need to keep my follow-up going. I need to know that family history, like we mentioned before. I need to know if I can find these things out, because sometimes we don't know these things, but sometimes there's a special caveat to our family tree that we have some strange genetic disorders that cause us to have problems. Lynch syndrome, if you've ever heard of it, it is something you need to know about in your family, but Lynch syndrome is a form of a genetic disease that falls into this category that puts people at much higher risks for polyp development. And it can be as young as the early teens and 20s that people will develop polyps. And so when I do a test for someone that maybe has some symptoms and I go in and they have lots and lots of polyps, then I start doing this kind of investigating to see, does this person's family tree carry some kind of a genetic predisposition to make them higher risk for this disease? And as I mentioned earlier, a personal history of diseases that cause the bowel to be inflamed, like Crohn's disease or ulcerative colitis. Anybody know about that? Anybody have any personal, or you don't have to tell me your personal experience, but have heard about that? Those diseases? Yeah, so they're tough diseases. I, unfortunately, have that in my family tree. I have a daughter who is treated for Crohn's disease, as well as a nephew, and I had a grandmother who was treated for Crohn's disease. Crohn's disease is a disease that causes inflammation in the bowel, and it causes ulcers to be formed, and it can cause bleeding, and it can cause a lot of problems with poor digestion. So it can make people very underweight. It can cause people to bleed and have problems where they don't make enough blood cells because they're losing that blood through these ulcers. Ulcerative colitis is a similar disease of the bowel that can cause the same kinds of problems, but it tends to be right at the outlet of the bowel, at the rectal area, so it causes a lot of bleeding. It's a big problem with bleeding and anemia. But these diseases create inflammation or swelling and changes to the colon tissue, and when we have that precursor, cancer tends to follow. So we have to be mindful of the diseases that can put us at higher risk for something like colon cancer. So just be aware of these types of things that make us a little bit higher risk for a disease like colon cancer. Now, this is the best medicine I can give you. Act early. Don't be afraid to go in and ask those questions. I'm having these changes. What do you think's going on? Act early. Don't wait I've done this. I'm notorious for this. I'm a nurse. We tend to be some of the worst patients on the planet. But, you know, not with my colon necessarily, but with other things. It's like, my knee has been hurting. Well, how long has it been hurting? Just 6 months. No big deal, right? Don't wait. go in when you see some of these things and get some help to figure out what it is that's causing those signs and symptoms, because we don't want to let it go so far as to have to deal with some of our mountain examples like we had earlier in this morning. So, know your family tree, know your first degree relatives. If they've had cancers, how old were they when they were diagnosed? That's a real important question to ask. And the reason is, particularly for colon cancer, is if let's just say, this is a hypothetical, let's just say my mother had colon cancer diagnosed for herself at age 52. She was 52. Then I need to go at 42 to have my first colonoscopy. Okay? Does that make sense? So knowing your family history, mom, dad, brothers, sisters, if any of them have been diagnosed with colon cancer, if that cancer was diagnosed, we need to go 10 years earlier than they were old when they were diagnosed. Does that make sense? Or 50 for sure. We have to go by the time we're 50 for sure. So at least 10 years prior is when we want to have those things done. So my very first example I showed you this morning, my friend's dad, whose son was diagnosed with precancerous colon changes. Every one of his siblings went that year and had their testing done. Guess who didn't go? Dad. Dad was like, nah. He's that kind of guy. You know? It happens that way sometimes. So know your provider that you see, go in, be checked on an annual basis for your regular checkups, and have the conversation about, I have not had my colon testing done, where should we start? Where do we go from here, right? Always, always, always be in charge of that conversation. Say, this is my life and I need to be in charge of it, and let's figure out how we're gonna go about doing this. Schedule on time for your testing as best you can. Get rescheduled for those follow-ups when they're recommended. Don't wait for signs and symptoms of this disease. We learned in a couple of pretty extensive examples this morning, waiting for signs and symptoms to occur, we're already behind the 8 ball when we do that. So let's get in front of it. Know if you're in the high-risk category. Do you have a family history? Do you have a personal history? Get tested and get followed up. I'm repeating these things because these are the most important caveats to this situation. This is just a snapshot picture of what I've given you in a handout in our awesome packet that you were given this morning. I cannot take any credit for that packet. She did an amazing job on that packet. I just gave her the things to put in for me. Colon cancer is a deadly disease, as we talked about before. We are seeing far too many people die every year from this disease. It does not have to be that way. We can get in front of a disease like this. We can get our testing early. We can get our testing as often as we need it to be, and we can get things checked out. Prevention is still the best treatment for a disease like colon cancer. I don't want a third of my colon removed. I don't want 70% of my liver removed to be able to treat this disease. I want this to be something that we can pick up early in the disease process and take care of it before we have problems. Does anybody have questions?
I have a comment.
Yes.
I think we have to be conscious of this fact. We are responsible for our health, not our primary care. We are responsible. I'm responsible for what goes in here and what comes out of here, and that affects my colon. Exactly. So, matter of fact, we talk. Well, anyway.
You are 100% right, and that's why I go about it as a team member when it's time for people to come and see me as a primary care, because I agree with you. They're not responsible for my decisions. I am simply your tool to get the tests that you need when it's time to come in and see a provider of any kind. So you're absolutely correct. We get to be individually responsible for our health care.
Let me tell you about although I was diagnosed with cancer a few years back, and I studied a lot about colon cancer, But recently, when I was told we was coming to this, and all the things that I've learned, I had put aside, I reached back and got them.
Yeah.
You got to stay on top of it, else you'll fall back
Yes.
to where you was.
Well, and that's just it. You're right. Like this article that I brought, this was Monday. I have to stay on top of it too because it changes like that.
Yes.
And what we can do about colon cancer might change like that.
Yes.
And so you're absolutely right. We've got to stay on top of it.
Well, the key is you got to keep clean. You got to keep going clean.
Got to keep going clean.
Oh, well.
Yes, ma'am.
Well, I was thinking when he was saying that with food, we look at smell, how it looks, how it tastes. We're all grateful. Most of us in here are seniors, so God has been good to us.
Yes.
But we also in that hard, we've been doing this a long time. And it's not gonna be easy to live the lifestyle, or at least to start at this point, the lifestyle. I'm just speaking basically for myself.
Yeah.
And as a senior, I've been going to a lot of seminars on health, on history,
Yeah.
and on just fun things to do. And I'm grateful for this. Like I say, I don't have two factors that I don't have to go out here and wrestle with, even when I walk out the door. Smoking is one. You know, I did learn about the colon need movement. That's the most important thing that I will remember today. I remember all this other stuff. I didn't realize how much the right kinds of food gives the colon movement.
Yes.
But getting back to the other part, like I say, we're kind of old. And I appreciate this seminar and all those other things that I've been going through lately. I just wish our kids knew about it.
Amen.
I
Because
agree.
it's hard
It is.
at our age to change. Not impossible,
No, it's
but
not.
hard. But if you know, the more you know, the better off you'll be starting early.
The earlier we
Yes.
get that information, you are so correct. You're so right. And it is hard because there's a lot of information out there. I get a little information overload sometimes, and it's like, how do I dig through all this stuff to find the really important stuff? And I hope that I was able to do that for you today in terms of colon cancer. But I think you're absolutely right, and I think as a society, I think we should, try and help each other figure out ways to get the same information to younger people, because, 50 is an important number, but I think my kiddos need to know that 50 is a thought that they need to be thinking about now, in that I need to plan for these things and I need to do all of the do's on that list as much as I possibly can to be able to, at 50, not have any polyps at all. But, good point. Yes?
So it's a perfect place to say that those of you who are not from Central Missouri, everyone else came here today because you have a responsibility. And your responsibility is to take this information and share it with your community. If you had the notion that you were going to share it with other seniors, be informed by what she just said, that this is information that's not just for someone who is 70 having to make up for time. Someone who is 60 who should have been in the next colonoscopy.
Right.
But someone who is 20 or 15.
Exactly.
So as you're thinking about the people with whom you will share this information, think about younger audiences.
Absolutely. And I can tell you from example, and it breaks my heart when I tell this story, my nephew was diagnosed with Crohn's when he was 16. My daughter was 14 when she was diagnosed. But he thought it was normal to have blood in your stool. Because he always did. He said, well, no one's ever talked to me about that. Why would we, right? So you're absolutely correct in saying, talk to your younger folks, talk to your family, talk to your friends. Don't be afraid to have those conversations like my daughter jokes about that, Mom, we talk about poop and other people don't talk about that. No, they don't. But maybe they should, because she too thought it was okay to have really achy joints and bowel changes. And you're not supposed to have that when you're 14, or ever, in my opinion. But something's not right. And when we don't have those conversations with our younger populations, or whoever that may be, we begin to think those abnormal things are normal, and we don't do anything about it because we don't know any different. And it's not okay to have achy, creaky joints, and it's not okay to have blood in your stool, and it's not okay to find some of those things. And it is okay to ask someone for help and figure out, why is this happening and what can we do about it? Because it is so important.
I just want to say that it's really been informative for me because colon cancer runs in my family.
Yes.
I have a sister now that has just been given the news that she's in remission.
Oh, that's wonderful
And,
news.
It's been like
Bang.
it's been really bad,
Yes.
because it's only 3 of us left, and she's the next oldest. And she really had a real bad bout with it.
Did she?
Yes, she did. So when you talked about the fiber, I've had people ask me, I've been complaining about my movements, and I have people, do you eat bread? I said, I eat it sometimes. Well, girl, you gotta get fiber, and
Yeah.
so this is really, like, my eyes is like pop.
Wide open.
Even though I've been told I need to intake more fiber.
Yeah.
This is really like, because I don't want to be a statistic. I don't want to have to deal with it.
Yeah. And I'll tell you, just the easiest way to go about getting fiber is, I prefer fiber to come from things that don't tell you how much fiber is in them. Like a fresh fruit or a vegetable. Not a box that tells you what's in there, because that means somebody's messed with it, right? Like he had mentioned before. So I love your fruits and vegetables as your primary source of fiber. Some grain is okay, but I prefer
what about the stuff they say like the fiber gummies or whatever? Do you recommend that? Because a lot of people say, I get the over-the-counter fiber.
If you can't do it any other way, I'll take it any way I can get it. Preferably, it comes from fresh fruits, frozen fruit, not just fruit, fresh fruits and vegetables, frozen fruits and vegetables.
And you know what? I eat a lot of
those
fruits.
routes.
I eat salads. I eat greens maybe twice a month. That's not enough, is it?
Daily. Every single day. So I am trained in something called functional medicine. And functional medicine goes way, way upstream and says, how can we fix disease before it happens? And one of the best things we can do from a functional medicine perspective is eat every color of the rainbow every single day in vegetables and fruits. And so, yeah, every single day we want to have all of those colors every single day. Yes.
Just listening to people talking about our audience, and especially the young lady who made the comment here, my thing is we need to lead by example. Even though we are older, a lot of us have grandchildren that come to our houses, our kids still come to our houses. Instead of filling them with every bit of grease and whatever, we need to start setting the example. And instead of giving them candy and all that, give them fruits.
Yeah. Exactly.
And in that way, when they're young, and the reason why I'm saying this is because I'm raising some brains. And people ask me, how do I get them to eat the way that they eat? I get them to eat the way that they eat because that's what I prepare in my home.
That's right.
And so if we're not preparing it, if we're just telling them, you need to eat fresh fruits and vegetables, they don't see us eating fresh fruits and vegetables. And when they come to our houses, we're not giving them fresh fruits and vegetables.
Exactly.
Then we're laying down on the job, and this has not done what it was intended to do. Because it goes back to what you said, is that we need to prevent disease before it is started. And that is the key.
It is the key. It is the key. It is exactly what we have to do, because we can't wait until it's happened and try and, a lot of our research is looking at how to fix it after it's broken. Why not break it to begin with? Yeah, go ahead.
Oh my, I got the microphone.
You got the mic. It's your turn.
Okay. Well, if you're having a side conversation you're preventing somebody else from being heard. So please wait until it's our networking time to have your side conversations. Thank you.
I just had a question and a comment. A question about BMI. What is it? Is it fat or, you know?
It's your body mass index. So what that number is not looking at just weight. It looks at your body type and your height and weight calculated together. And so that's what that BMI is looking for. And we're wanting to have more, it's a more of a normalized look at the weight categories, as opposed to just saying this is how much you weigh and you're a female. We categorize it by height, weight, and a few other calculations.
Okay, and do you think all of our colon problems are because we're overweight? You know, in America, we're prosperous, we eat, we can do anything and have anything, and we buy anything, so we overeat. I think we're the fattest people in the world.
We are. You are correct. You are correct. You are reading your statistics correctly. We do have, it is a huge piece of what is impacting our colon health. I can say that for sure, because the studies are out there. This one that was just published on Monday is drawing those links between the kinds of foods that we eat as much as how much food we eat. So it can be a combination of both of those things, not just one or the other. I would love, call me when it's time to come and talk about a healthy diet planning, because one of the things that I think we forget about is that there's lots of different kinds of fat. This particular research article talks about fat, but not all fat is created equal. Fat that I get from an avocado is a very healthy, great choice of fat, and fat that I get from canola oil is not such a great choice of fat. And so all things are not created equal. So sometimes it's what we're choosing to eat. If we're picking processed foods or things that come out, I talk to my patients about, if it comes from a factory, leave it there. If it comes from the ground, off a tree or off the animal, go for it. You know, it's a much better choice. And so all food is not created equal. And not to get too in-depth in that conversation, but real simply, food that is processed or goes through a factory to be created has taken away some of the things that our body's natural action should be doing, like processing fiber. And the colon doesn't like that. The colon gets very upset when we eat overly processed foods that don't have a lot of fiber. And sometimes the way that companies will try and get around that is they'll add extra fiber to it, but it's not the same as getting it from a fresh piece of fruit or vegetable. Excellent question, and you are correct. You are correct. It's what we're eating as much as how much we're eating, and a combination thereof.
Since you mentioned it, our body's organic.
Yes.
And we put inorganic food in our bodies, and it don't work well.
No.
And our medical physicians, the medication they give us is inorganic. And what we do, we get all this toxin in our body because of our medication.
Yeah.
And we get more harm done than good.
In many cases, yeah. So you're absolutely right in that consideration, and you know, putting in the analogy that I use for that is, if you drive a car that takes unleaded gas, that better be what you put in it, right? Because if you put in diesel, which is those inorganic foods, it's not going to work very well very long. So always fill your tank with the things that your body is capable of eating, which are our fruits, vegetables, meat products, etc. Not those foods that are created in a lab somewhere to kind of be food. It's not food. Any other questions? Thank you guys so much. I appreciate it. I've kind of gone over a little bit, but I know we had a little shifting. I really appreciate you spending the morning with me. I've really enjoyed putting this lecture together for you. Thank you so much for having me, and enjoy the rest of your day. Thank you. Thank you. Oh, that has been wonderful. Thank you.
I have to share this with you. Before Miss Yvonne and I, actually Miss Yvonne called Miss Nolph, and we had a very good conversation on the phone with her. And after the phone call that she had made, I said to Miss Matthews, I said, I have to meet this lady. You could tell from her energy that she is quite inspirational and motivational. And I thought I have to meet her. And then when I met her this morning, I thought, oh my. So please join me in a big round of applause again for her. And at this time, we will transition into lunch. And also, there are post-tests that I would like for you all to complete. And I'll just leave them on the table. But before we transition for the lunch, we will also have following will be the training, and that will be conducted by Ms. Yvonne Matthews, who is the Associate Administrator of the Lucy programs and the coordinator of the Paula J. Carter Center. Also, we had some other seniors who just came in and arrived, and a staff person from St. Louis. So please just tell us who you are. St. Louis.
Jennifer Davis, Sharon Casey, Taylor Smith,
Eddie Tucker.
Joseph Turner.
Mary Lardy.
Thank you, St. Louis. Well, at this time, we will conclude this session, and we will have our lunch, and I'll turn it over to Ms. Matthews. Thank you.